Let's just say she walks in with ovarian torsion. Her ovary is twisted. She doesn't want to know that her ovary being twisted is worth less money than a man whose testicle is twisted. And that's the case. I trained with some of the best surgeons in the world. They discontinued their GYN surgical services. And so women, they're going to have to wait or they won't have access at all. Urologists are not incentivized to take care of female patients. In fact, I know urologists, particularly in private practice, who are told not to see female patients because they lose so much money. Less than half of the counties in America have an obstetrics provider. The more I got into it, the more I realized that girls and women are set up to fail in the healthcare system. The biggest lie they've been sold about their bodies is...
I wanted to personally welcome you to the MedStory podcast. My name is Spencer Lalk. I am your host. And right now I'm actually just recording this directly onto my phone. So if it doesn't sound as good as the rest of the podcast, stick with me. The goal of the podcast here is to really start asking the really tough questions to our doctors and our other healthcare experts, because it's these questions that will help discover the solutions to all the challenges that we have in healthcare. So if you want to hear more conversations like this, I really appreciate it if you subscribe, follow along, and I look forward to diving into these conversations with you. All right, let's get into it. What is the biggest lie that women have been sold about their bodies?
Wow, that's a big question. I mean, I think the biggest lie they've been sold about their bodies is that they can't trust their own symptoms to tell them when something is wrong. And I hear that quite a bit from patients with pain who frequently have endometriosis. That's a really big one. That they have pelvic pain, they have a bunch of weird symptoms, they know something is not right, and they're told that it's normal or just part of being female. That's a pretty big lie. Another one is that a lot of the problems they have don't have good treatments. That usually comes from a practitioner who's just really in the dark about women's health. They don't have a lot of knowledge or know about what a lot of our specialties do. They don't know a lot about OBGYN, and women get this idea. Incontinence is a great example that they have to just live with the symptoms that they have.
What do you kind of wish that more mothers would tell their daughters about their body before their first OBGYN visit?
There's so many things. I mean, you could backpedal all the way to as soon as a young girl is able to learn that her body is her own and she doesn't owe access to it to anybody but herself is the first thing. And then the second thing I probably would say is to teach them that heavy and painful periods are not normal. That's something that people often normalize, and it's really debilitating. It keeps girls out of school, from playing sports, from socializing. That's a really big one. And then teaching girls about what is included in OBGYN care, if they even know themselves that OBGYNs are not just for periods and babies, that they take care of women through their whole lifespan. They do preventive care. They treat postpartum issues. They do treat painful periods, fibroids, bleeding, endometriosis, infertility, cancers, that there's just a lot that's wrapped up in women's health, and you can always get another opinion, and probably there's a specialist.
Gotcha. I mean, you're a big name for advocates for women's health, but tell me, what was that experience, or what was the story that you had that made you want to become such a big advocate in this field?
I think it's a few things. Number one, I come from a very outspoken political family. I have a father who was in public office most of my life. So I watched him say, hey, here's a problem. It doesn't seem like anyone else is speaking up about it or coming up with a solution for it. And he's trained as an engineer, but then went into politics and kind of continued to do both. So I really watched him be very talented at taking these really complex issues and making them into something that the public could understand, or people could understand why it was a problem. And I have a lot of other healthcare workers in my family. My mom is a pharmacist. I mentioned I have a big family as well. None of my siblings, my 7 younger siblings, are in medicine. If you're going to get them to listen to you for more than 5 minutes, you need to be able to explain things in a way that compels people to understand why something's a problem. So that was the first thing, is that I think good scientific communication or like communicating complex issues is super important. And then, of course, growing up, I started to notice things that I didn't think were fair between boys and girls, things with around contraception or bodily autonomy. I knew I really wanted to be a surgeon. And then the more I got into it, the more I realized that girls and women are set up to fail in the healthcare system. And when you're an oldest daughter in healthcare who's raised by people who teach you to stand up for yourself and speak up for things, you end up doing it in a quippy and literary way. So it just all came together. And I think it's super important to be able to be a good communicator of the systems you see playing out that other people might not be privy to.
Was there a moment, maybe in medical school or even working as a surgeon, that you can look back to and said, wow, this really is not a fair system and I have to do something about it?
Yeah, actually, I can tell you almost till the day. I don't know what the day was, but I do know that I was a resident on a night shift. I did my residency at Johns Hopkins, like phenomenal institution, obviously, top 5 OBGYN, women's healthcare. I mean, truly the smartest people I've maybe ever met were there. But I went to medical school where I work now at McGee Women's Hospital, which is a women's hospital. So it's this really incredible, there's only, I think, 3, I could maybe think of 4 if you pushed me, like women's hospitals in the United States, hospitals that do focus on OBGYN. So I was really used to both my patients and my colleagues having a tremendous amount of respect for both their skill and their disease. And then I went to Hopkins, which is a hospital where all of the specialties are mixed together. And so it's one big ship hospital where OBGYN is just like on one floor. And particularly like the OB, the labor and delivery unit had been recently remodeled, so it was very nice. But the gynecologic surgery space was not nice compared to what I saw my co-residents in orthopedics and neurosurgery and urology. They had very different setups for their patients. I remember thinking like the rooms were nicer and they had more nurses. And when you were in the operating room, they had these dedicated teams of scrub techs and circulators who knew them really well and knew what all of the surgeons wanted. And they worked with them every day. And gynecologic surgery was rarely like that. We often had different, whoever was left over is who gynecologic surgery got. And I also remember feeling, as I talked to this, I had many friends who were not in OBGYN, who were other types of surgeons, talking to them about this. And they'd be like, oh, Jocelyn, we really respect you. We know that you're good at your job, but most OB-GYNs are not very good surgeons, or they don't want to be good surgeons. And they just had no idea what OB-GYNs and their subspecialties are really about. Or they'd be like, oh yeah, like gynoncs are good surgeons, but the rest of you guys are not. And so it was all of that. I just felt like we were second-class surgeons in that institution in so many ways, which again, it's like it's a nationwide thing. It's like this sort of attitude against gynecologic surgeons because we don't train in this common pathway with general surgery, and we're not like generating the dollars that orthopedics and neurosurgery and cardiac surgery are making for reasons I can go into more and that I've talked to you about. But I remember putting all that together and saying like, I train for just as long as you. I have advanced surgical skills. Like, why are my patients not getting the same resources? And why am I not getting the same respect that you're all getting? And then I dug into it more, and it really all comes down in a lot of ways to money and honestly, some sexism against women and their surgeons.
So if you are a woman, or if you are a man that has a woman that you care about, whether it's your mom,
Yeah.
your wife, your sister, I think that you really need to listen into this next part because Jocelyn and I were talking about this. And after she was telling me it, I was like, oh my God, like this story needs to be shared.
Yeah.
And I don't even know where to start because I think we need to start from the beginning of why this is a big deal. Why should women care about this? And then we'll kind of figure out, we'll paint the story from there. So let's start off. Why should women care?
So I think what we're going to talk about is why, if you're a woman walking into a hospital with a gynecologic problem, that problem is not worth a lot of money to that hospital. And it's worth less than like a man walking in with a urologic problem. And that is important because the demand for gynecologic surgery is extremely high. GYN surgeons and obstetricians do the two most common surgeries women will ever get in their lifetime, which is a C-section and hysterectomy. So extremely high demand with a very long wait times and very little incentive for most hospitals to provide those services because they aren't being reimbursed well for them. And that creates a public health crisis where if hospitals don't want to provide OBGYN services because they aren't lucrative, then women are going to be shoved more and more into these like rapidly declining like specialist centers, usually in urban areas. And in these non-urban areas without specialists, you simply won't be able to access this care. And so we actually see like labor and delivery units closing all over the country. Less than half of the counties in America have an obstetrics provider and have a place to safely deliver their baby. So that's a huge problem. And then gynecologic surgery facilities are also being discontinued all over the country. In fact, where I trained in Washington, D.C. to do surgery at a very high-end surgery center with some of the best surgeons in the world, they discontinued their GYN surgical services after the COVID pandemic because they simply could not afford to give the operating room, which is expensive to run, the nursing staff, the resources. They just could not make the same amount of money in that room that they could make doing orthopedics. So they discontinued those services. And so women, they can't be seen. They're going to have to wait or they won't have access at all. And it's a really big problem. And it all goes back to a bunch of very discriminatory policy decisions that were made in the early 90s.
I think that when I hear that, someone might immediately go and say, oh, wow, this is the hospital's fault for not wanting to do that. But I
Yeah,
think what people need to understand is that hospitals already work off very thin
they
margins.
do.
And their job is to keep the doors open so they can continue to help people. And
100%.
it's a business, right?
It's a
So they
business.
have to make money.
Right.
So when it comes down to it, it's more of like, why are they being paid less for a surgery that might take longer or as an equally skilled surgeon? So tell me, how did this come about?
Yeah, I'm glad you made that point. This is not a nefarious thing. I mean, I think in most circumstances, definitely not. A bunch of executives are thinking like, oh, we're going to screw over women. That's not the case. And I mean, I've been very lucky where I work is a women's hospital. So the infrastructure has been there. The community commitment has been there. We found ways to make sure we always have these services. But I have colleagues like in Texas and Tennessee and Michigan, places that they're in DC, their facilities have closed. They're not allowed to operate there anymore. So this all began in the early 90s when Medicare and Medicaid were trying to figure out how to decide what different specialties and services needed to be reimbursed for medical care. So like you have a heart attack, you get a stent put in, what is that worth? And so they came up with this system that was implemented through the Social Security Act called the Relative Value Unit, which is exactly how it sounds. It's what is a heart worth relative to a uterus. And RVUs then, when you get paid, this is the most simplistic way of physician payment, but it gets multiplied by a conversion factor, which for Medicaid and Medicare is a set dollar amount. It changes year to year. I don't exactly know what it is this year, but let's just say it's $50 per RVU. The RVU system is also used by private insurers just because it's already in place and they assume that those are good estimates of what things are worth relative to each other. And so 80 to 90% of the RVU that is determined by the Centers for Medicaid and Medicare Services are picked up by insurance companies. And then insurance companies get to decide how many dollars they're going to reimburse a hospital per RVU. And it's not always equal depending on what your specialty is. So there's that. That's the first thing I'd like to say. But the second thing that I want to say is when they set up the system, they made the pot of RVUs finite. So it's called the budget neutrality clause in the Social Security Act. So for all of medicine, everything we do that has an RVU assigned to it, we have a finite number of RVUs for everything. So when they first divvied it all up in the early 90s, the American Medical Association was basically put in charge of building this committee called the RUC, which stands for the RVU Committee. And it had a representative, and still does, for theoretically a well-represented diversity of specialties in medicine. OBGYN has one person, neurosurgery has one person, orthopedics has one person, etc. They started out assigning RVUs using this report that was written by the Harvard School of Public Health. And honestly, the things that were given the highest value in that report were cardiology, like cardiac. Like, what was killing men in midlife at the time? It was heart attacks, and cardiac stuff was worth a ton of money in that report, and women's health was really left out of the report. So it set us up for failure in a system that was designed to not let us to shift RVUs around with any type of fair system. Because once everything was locked in, if you have a finite pie, you can't pull money out of cardiology and put it into OB-GYN without an actual fight in this committee. And so we were set up to fail from the beginning. And as our field has gotten more and more sophisticated, as our surgeons have gotten more and more training, we haven't been to keep up with the amount of money these other specialties are capable of making. And so one of the examples I give all the time is endometriosis surgery, which until recently actually didn't have any diagnosis codes for its variety of complexities at all. And it still only has one single billing code for endometriosis excision. It's the same as endometriosis ablation, which is when you go in and just burn the endometriosis. It can take 15 minutes. Or you go in and completely remove the endometriosis like a cancer, which can take 6 or 8 hours. And no matter how long it takes or how complicated it is or how much bowel adhesions you break up or bladder and ureter dissection you do, you get the same amount of money, and it's 12 RVUs. It's not a lot. And then like a knee scope or a shoulder scope is worth like 15, 16 RVUs, which takes a half an hour. I mean, more complex, maybe an hour. But I mean, of course, if you were a hospital administrator, you'd hire and prop up the orthopedic surgery department. They're like making the same amount of money in an hour that it takes me like 4 hours to make that amount. So it's just pure money. It's like dollars and cents. And I don't blame them, but we have not really been set up to revise the system.
This is really eye-opening. And
Yeah.
I think that one thing that I want to point out is that with this budget neutrality clause is that it is pretty much a budget that's set by Medicare and Medicaid.
Exactly.
And they have to just figure out how are they going to distribute it out. And it's a set budget. And we get that. We need to stick to our budgets.
Sure.
Now you have the board members, which is that RUC committee. And they're sitting there saying, okay, if I can have the money go towards my specialty, then I'm going to advocate for that,
Of
right?
course. Why wouldn't you? I would.
In an ideal world, you would think that within that RUC community, it is equally equitable across specialties.
Yeah.
But what's the truth?
It's really not. I mean, I didn't even talk when we spoke earlier about the difference in the amount of money that relative specialties have to lobby within the RUC. But OBGYN only has one representative for all of OB and GYN, which are really two separate fields of medicine. You could even argue it's 7 fields of medicine if you take into account all the infertility specialists, the cancer, the endometriosis and fibroids, the prolapse, the complex family planning, high-risk OB, and then generalist obstetrics, is being represented by one person that's appointed by ACOG, which is the biggest organization in OBGYN, and the vast majority of ACOG's membership are general OB-GYNs who mostly do obstetrics. And so gynecologic surgery is not at the table at all. There is no gynecologic surgeon who is representing our specialty at the RUC. And so what ends up happening, since OB-GYN has this like little slice of the pie and really only has power over what we've already been given, I don't blame them either. Like, the ACOG representative tends to favor who they are representing through ACOG, which is general OB-GYNs who are not doing gynecologic surgery. So over time, gynecologic surgery reimbursement has gotten actually worse and worse. Obstetrics has gotten a little better. I don't want to say obstetrics doesn't need more, because obstetrics is also wildly undervalued. And it's just insane that like it pits OB-GYNs against each other when really there's specialties that are getting these like huge paydays and they don't have as much training as we have, nor are they, if you do like economic analyses on the amount of like economic impact the disease processes they treat have on like the return that you get into the economy for treating it. Like nothing puts more into the economy than obstetrics. You're literally like producing more workers. The economic impact of certain diseases relative to the amount of money we like spend on them has consistently been shown in women's health to be completely disparate, like not proportional at all. So the rec does not really represent an economic reality, especially for women.
Gynecologic surgeon seems like that'd be pretty niche. Is there actually a big need for surgeons like this?
Yes, there is. There aren't very many of us, but the most common surgery that women in the United States over the age of 65 get is urogynecologic surgery, which 65 is not that old at all. My parents, who look very young to me and are extremely active, are 65 years old. They still work. I mean, we should be taking like really good care of them. Yeah, it's the most common surgery that women over the age of 65 get. And there's only one urogynecologist for every 100,000 women in the US. And we only train on average like one, maybe two at the most, like one and a half at most urogynes per state per year. So the demand is really huge, and urology is not really training people to do female urology. For all the reasons I've just said, urologists are not incentivized to take care of female patients. In fact, I know urologists, particularly in private practice, who are told not to see female patients because they lose so much money seeing those patients relative to the amount of money they can make seeing a male patient for a very similar problem.
So you're telling me that we have an aging population and the number one surgery that is done by females is done by a urogynecologic surgeon, and we're not producing enough of these surgeons? If we continue in this direction, what does the future look like?
Oh, I mean, it has been predicted both on the OBGYN level and the urogynecology level by I wish I had these numbers right in front of me. I just looked them up. They're on my Instagram. But by
You're more than welcome to look
2040,
them up if you want.
yeah, we could. By 2040, 2050, the shortage will be in the tens, hundreds of thousands. I mean, it's really bad. Here, I'll just pull it up so I say the right numbers. But it really makes no sense. I actually talked about this a lot a few weeks ago when there was OB-GYN match day for all of medicine, and it's still incredibly competitive. Here we go. We are producing about 1,500 new OB-GYNs per year. We'll say 1,600 in the US for 170 million women. So you have 170 million women, and we're only training 1,600 new, and that's all of OB-GYN. That includes all the specialists that I just broke down. You get maybe one specialist per OB-GYN class, which is like 7 to 10 people. So yeah, I mean 170 million women, and we're only replacing the OB-GYNs that are retiring with 1,600 per year. It's not enough.
Okay, you've convinced me that this is a problem. It's a big problem.
Yeah, it's a
But
dangerous problem.
what's the solution? What can we do?
There's so many things that we can do. A lot of it does really come down. This is a very uncertain time, right, for CMS and also for Health and Human Development. But the secretaries of both of those cabinets are very powerful, and they can do a lot. So the Secretary of Health and Human Development, or I'm sorry, Health and Human Services, can structure the RUC however he wants to. So we can get more representation on the RUC. He could change the budget neutrality ceiling. He could get rid of the American Medical Association's involvement in the RUC at all and just come up with a whole new system, which I've heard rumors might happen. I mean, there's so many things that are being tossed out right now. Do I agree with everything that's being done? Absolutely not. But if there was like some good to come out of the chaos, if they're gonna get rid of the RUC system and rebuild it into something, I want to make sure that I work with some really influential, incredible groups of people who are ready to be there if and when that happens, so that if it gets rebuilt, it can be equitable to women and solve some of these public health problems. Yeah, CMS can restructure how they pay for things. Private insurance they don't have to take all of the RUC's recommendations. They can simply decide that women's health is worth more money. I mean, I don't think any insurance company is super excited to pay more money for a procedure that tons of people are getting, so then they'll have to pay more for it, but that could certainly happen. I mean, laws could be changed around this. There are law scholars that have written incredible works on this topic within the last couple of years. I work with two of them. Louise King, who is the director of reproductive bioethics at Harvard. She is an MD-JD, so she's a endometriosis surgeon and a lawyer. Works with this awesome guy named Chris Robertson, who's a professor of law at BU. They wrote a law review and basically showed that this situation as set forth by CMS is a violation of the 14th Amendment because it's sex-based discrimination in what we're paying for as a government. And it's also a violation of the non-discrimination clause of the Affordable Care Act, which who knows how long any of these things will be around. But there is like legal precedent for the fact that this is simply at its core like sex-based discrimination, saying women's bodies are not, and the healthcare they require are not worth as much money as equivalent male diseases. So that's something that can be done. I guess we sort of start there, but just, I mean, thank you for having me on your podcast. Raising public awareness of this, public awareness of these sorts of issues changes a lot and changes it quickly. It gets the attention of people in Congress. I don't think any woman wants to hear that if she walks into a hospital in labor, I guess there's no male equivalent for labor. Let's just say she walks in with ovarian torsion, her ovaries twisted. She doesn't want to know that her ovary being twisted is worth less money than a man whose testicle is twisted. And that's the case. I mean, that's a wild comparison. It's very apples to apples, and it's very much not fair.
I think that this is one of the biggest challenges, and you talked about this earlier in the podcast, is that you and I know that this is a big problem,
Yeah.
but finding ways to communicate it so that people will listen and that they actually care,
Yeah.
and it moves them to take action, that's the challenge.
Yes.
You know, and that's why we need to have these deep conversations and then try to spread it as much as we want and get in front of the decision makers, but also empower other women and their partners and other health practitioners to understand how big of a deal this is and how much this is going to impact us if we don't change.
Yeah. I mean, I would hope that, thank you so much as a man for having me here to talk about this, because I mean, this does affect men. Like, men are involved in the building of families. They love I hope, their mothers, wives, sisters, people who are in pain. I've had men come into my office and say, honestly, this is a separate podcast, but I'm here to advocate for how much pain she's really in. People seem to believe her more if I'm here. I mean, and if you're waiting months and months for an appointment to see a specialist, of which there's very few and are not being given the resources to operate as much as the disease process demands, then you want to make your appointment count. So yeah, there are absolutely men who show up.
I would love to sit down with you and have a full podcast on that. This podcast will be 1,000,000 hours long, so we won't dive into that right now, but I would love to sit down and talk about that because that's something I want to learn about as well. I have now created a lot of content with different OBGYNs, and the fact that I've learned so much about the women's cycle, the reproductive system, I feel has made me a better partner and more empathetic.
Of course.
I think that should be a lot of men's goal.
Absolutely. It'll truly be, it's good for men and women, because I mean, women do so much for all of us. Like, they take care of everybody, so we should take care of them.
Yeah, they're badasses for sure. So tell me this, I want to get into kind of an actionable part of the podcast where if you were giving recommendation to one of your patients or your family, and let's say they have incontinence, okay? Let's guide them through this. So let's first start with, how do I identify if I am incontinent?
Yeah. Wonderful. Love that we're pivoting to like the Urogyn portion of the podcast. So I know people who don't even know what the word incontinence means. So I guess let's start there. Incontinence is when you have bladder accidents, when you pee your pants, when you're not on the toilet, you're not saying, okay, time to empty, little bladder, and it just comes out no matter what. So yeah, I mean, navigating someone through that, I think if if everybody knew what a urogynecologist was, it would be so easy, because if I know someone with incontinence, I'm like, please go see a urogynecologist. Just go, because then we'll do like the whole evaluation. We'll see if it's like the kind of incontinence we think will respond to pelvic floor therapy, will respond to medication. Is maybe it's another medical problem that's making it a lot worse, like diabetes? Is there a neurologic problem happening? Do you have prolapse? Do you have, God forbid, like a fistula? I mean, there's just like a lot of complex things go. Do you have a UTI? Do you actually not have incontinence at all? Is it? So anyway, that's sort of where I would tell people to start. A lot of people don't have access up front to a urogynecologist. So I would say go to your OBGYN. Some of them absolutely can get started with the basics. Is this leakage with coughing, laughing, sneezing? That's stress incontinence. Is this leakage because you can't make it to the toilet in time? That's urge incontinence. And they could probably figure out, like, could we start you on a medication and get you into pelvic floor therapy? Maybe it's genitourinary syndrome of menopause is playing a role. They can put you on some vaginal estrogen. But if those things aren't happening and it doesn't seem like your OB-GYN knows a lot about incontinence, I would hope that at very least they would refer you.
For sure. Okay. So let's start from most conservative to most extreme. Okay.
Yeah.
So you go in, what are some cases where you might say, you know what, I only think you need a medication or pelvic therapy?
Yeah. And that's honestly a huge number of patients. People who come in and see me, they're like, I don't leak all the time, but if I like don't get to the toilet fast enough, or if my bladder gets too full, I just can't make it. Those are people that after I make sure, number one, they don't have a UTI. Number two, they're emptying their bladder well. Number three, they don't have a prolapse or some obvious mass or some pathology happening on their pelvic exam. If they're peri or postmenopausal, I put them on some vaginal estrogen cream. I send them to pelvic floor therapy. And that's usually where I start, is I do that first. That helps an enormous number of people. If they do that and it's still not helping, then those are probably people that I'll try a medication on. Conversely, if it's somebody who is a little older, has more comorbidities, I don't think they can really access pelvic floor PT. They're leaking like all the time. Like they're like, I can't even get out of bed in the morning. I'm already leaking. Those people get a medication. We usually start them on a med at the jump. And then I usually will actually talk to them. You said, what are the like more extreme things? These are what the description of what we're talking about, not being able to make it in time. Like I said, is urgency incontinence. I'll talk to them about some of the bigger guns that I have. The most common thing I use is Botox. You can Botox the bladder wall with a tiny cystoscope, which is a camera that goes in the bladder. That is extremely effective. And then the most invasive thing is called sacral neuromodulation, which is like a pacemaker for the bladder that we put a little battery in the butt cheek, and then there's a wire that goes to your spinal nerves.
Wow. So this sling, is that not an option for incontinence? Is that a different thing?
Yes, great question. So a sling is used for stress incontinence, which is the women who are leaking with coughing, laughing, sneezing, or exercise. So they can usually make it to the toilet in time, but they leak when they put pressure on their pelvis. That's why we call it stress incontinence. I once had a patient like get upset with me when I explained to her that's what she had. She's like, I'm not stressed. Everyone tells me I'm stressed. I'm not stressed. Like, no, it's like stress on your pelvis. Like, I'm not saying that you're stressed, but it is true. We often blame everything wrong with women on stress. So maybe we should rebrand that. But slings are for stress incontinence. And so the least invasive thing for any type of incontinence is pelvic floor therapy, as I said. We also could use something called a pessary for stress incontinence, which is like a little support ring that goes in the vagina. They come in a couple different shapes nowadays, but basically the idea is that it puts some temporary like upward pressure underneath the urethra to hold the urine in, so that if you're out for a run, you're not like leaking a little bit every time your foot hits the ground. And then the next thing, which is procedure based, is called urethral bulking. So I mentioned we can do Botox for urgent incontinence. We can do fillers for stress incontinence. So anyone who like, I joke to my patients, I'm like, it's like lip fillers before your urethra. Actually, here, I'll grab my pelvic model.
Teach us.
Show you. Yeah. So
Yeah.
we inject urethral fillers like right in the urethra with a really small, even smaller than a normal cystoscope, a really small camera. And so that clumps up the urethra so that you don't, same thing, leak with like exercise and cough, laugh, sneeze. It works best in people who don't have like really severe stress incontinence. And the people who have like the worst stress incontinence, they're like, oh my God, I can't even turn in a chair without losing some urine. Those are the people who get a sling. And a sling goes in the vagina, like under the urethra, and comes out right behind your pubic bone. So that's what slings are for. And they are great. They're really good surgeries in the right patient. Like anything, you have to choose the patient properly. Like, what are their goals? What are their risk factors? How bothered are they by this problem? That kind of thing.
So I've worked as a physical therapist for many years, and I've worked with many
Mhm.
women that are in their second half of life. I'm going to be honest, it seems like the ones that have incontinence, it would be majority of them.
Yeah.
So if it's majority of the women,
Uh-huh.
does that just mean it's normal?
It's a great question. I always say it is not normal, but it is common, obviously. Like, you're right, half at least of women have some degree of incontinence after menopause, but it starts much earlier. I mean, there's large proportions of women, a quarter to a third in women in their 20s and 30s who have some form of incontinence. And some women, it's like drops and they're not really bothered by it at all. And it's like, this is no big deal. But yeah, it really starts earlier than people think. And it slowly over time takes you out of the life that you probably really would prefer to have. People who can't get to the toilet in time, don't leave the house without knowing exactly where all the bathrooms are, or they don't go at all. They're like too nervous to go work in the office for or go to church or go to a meeting if they think that there won't be bathrooms. They are afraid of having an accident. Women who have stress incontinence stop doing more high impact exercise or lifting heavier weights, which are all things that are really good for your longevity and your cognition. So it's slow over time. It like leads to a lot of frailty, a lot of avoidance of social situations, all of which makes you old in not a good way. So I think it's so important that as urogynecologists, people know who we are and know that we can treat, really decrease the amount of incontinence that they have so they can get their confidence back and do all these things that are going to keep them healthy that they're avoiding. So I think it's one of the greatest things we can do for women and their quality of life.
If you say it's common, nearly half of the women,
Yeah.
what I found is that many of them are embarrassed or ashamed to talk about it.
Yep.
Why do you think that is?
It's, like, really embarrassing to pee your pants, and a lot of them they have bowel incontinence too, not nearly as many, but not an insignificant amount. Yeah, I mean, it's something that's associated very much also with ageism. Oh, if you pee your pants, you're like an old lady who smells like pee, or it's like you're not whole anymore. Something about your body is broken or not worth working or dirty, and you're just like, "Oh, like, I don't wanna talk about it," but if it happens to half of people, that should not be something embarrassing if it happens to almost everybody, but it is. It's, like, something that's seen as very, like, icky and not associated with the qualities that we as a society celebrate in women, which is to be perfect and keep all your bodily functions to yourself.
I think there's two big takeaways here. Number one is if you are experiencing incontinence, that you're not alone. It's actually
Yeah.
much more common than you think. And know that if you look around and if you see, it's pretty much 1 out of 2 people is going to be experiencing it too.
Yep.
So those are your people. But then number two is that don't just sit there and think, oh, if it's happened to everyone, it's just part of life, because there
Yeah.
are things that you can do proactively or even reactively that can help make your situation better.
Sure. I mean, there's so many other things like that we treat medically that are common and doesn't mean they're normal, like glasses. It's just, I can't see, I guess, half all these people that wear glasses is just part of life. Maybe optometrists shouldn't exist, or like erectile dysfunction. It's, oh man, this happens to a lot of people. It must be normal. We just shouldn't intervene. It's insane. Like, we intervene on so many things that happen to so many people, and it's not even a question. But this is one of those things that we've just convinced women is like part of being a woman. No.
So, what do you want to say to that woman? What do you want to say to that woman that may feel ashamed or not certain what to do?
I mean, I'm grateful that if I actually am talking to that woman, at least they're talking to me. And I'm a urogynecologist, and I can really sort of destigmatize and at least normalize the experience of seeing me for it. I find that I can usually convince them pretty quickly. I'm like, "Did you know that you could fix this? You could not have to deal with this." They're like, "That sounds nice." And you're like, "Yeah, I mean, it does. You should totally come see me."
Speak to that woman that's listening to this in the car right now.
Yeah. I mean, don't wait. You really think about what I've said. Like, in what ways is your bladder perhaps ruling your life? You might not think of it that way, and it might not be such a big deal to go out shopping and be like, "Oh, where's the bathroom?" But if it's starting to really make you second guess, like going on that road trip to visit your kids or your grandkids, or you don't want to do, certain types of activities with your friends, like dancing or jumping, maybe you just go get an opinion because it might be an easier fix than you think.
Ah, that's amazing.
Yeah.
So tell me, Dr. Fitzgerald, say a woman is struggling with this, and if they want to learn more and they can't get right into their OBGYN, do
Right.
you have some resources for them that they can actually go and check out?
Yeah, absolutely. My favorite one for patients is a website called voicesforpfd.org, and PFD stands for pelvic floor disorders. I did not name the website, but it is the patient-facing website of the American Urogynecologic Association. There are patient handouts on there that are really very good. They're written by gynecologists across the country, and I use them in my practice. They're free to download and print. They have some really good pictures, and they have handouts. They actually have ones that are like normal size and then a larger print that are easier to read for each of the topics that and more than I've discussed here today. Exercises for your bladder, different types of incontinence, what is prolapse, what are pessaries, what is vaginal estrogen used for, how can you prevent UTIs, bowel incontinence. I mean, there's what type of surgery are available for a lot of these things. It's a really great website.
And then what if they want to learn more of you? What if they're liking what they're saying and they want to find more about you?
You are more than welcome to find me on social media. I'm on Instagram at JJ Fitzgerald MD. I'm on X at the same, though I haven't been using that very much lately. Blue Sky. I do have Blue Sky account with the same handle. And I'm on LinkedIn. If you're a professional networking person, you can find me at all those places. And I'm very Googleable.
Yes, you are. It's because you've been brave enough to put your voice out there. And I hope that this is one of many conversations that we can have because I love talking about all these things with you. And it's really nice to talk to someone that's so knowledgeable and can communicate it so clearly. So I really appreciate you taking the time and sitting down to talk with us.
Thank you so much. I mean, thank you for building the platform and being so curious, and it's been delightful.